So a lot of what I'm going to talk about is kind of follow up and augment what Dr. Musi was speaking about. We've been doing a lot of work with him, but I think I just want to give a different perspective than what we've had today, specifically in our diverse communities. So it's why are we talking about this specifically from a Black perspective? I find that a lot of times, even just saying the group that I'm from, people say that that in itself is kind of racist, or it's a very uncomfortable Canadian conversation. We don't like to speak about the differences between us because we pride ourselves that we're one conglomerate. But we know that even though as a number, like we're only 3.5% of the population, however, there's such a disparity in what we're seeing in our health outcomes. And so it has to be addressed specifically in our community. The first thing is that even to define what our community is the first problem. So we use the word Black as a very blanket statement, but these are a group of diverse communities that myself is representing and everyone else is speaking about. But we have to say why. Why are we seeing these type of differences? So to build on, what we kind of want to look at is there's some things that cannot be changed, but what are the modifiable factors that we can address and look at from within the community to say how can we proceed from here? Yeah, so I'm not going to go into detail about it, but there's a lot spoken about why are these differences. So we can try and address what do we think are these disparities that we're seeing. So there are very few congenital biological determinants that we see, but they're not uniform. So we keep saying that a lot of the research that we're seeing is out of the UK, is out of America. The genetic biological makeup of the population within Canada is very different. We have a very heterogeneous population when we're comparing to either like continental Africans or diasporic Africans. Even in America, their history, both socially and genetically, is very different. So the first context we always speak about is what does it mean when we're saying Black Canadians? What do we mean when we're speaking in this context? When we even say Black, this is a social contract. This is not something that is necessarily strictly defined biologically. We have made it so because we have intertwined this both socially and biologically, but we haven't further explored what are these determinant factors. We've taken for granted that the research that we refer to has been done in an equitable way. We've taken for granted that the people that are sampled, whether this was a uniformly identified, like was this self-identified as Dr. Musi said, or was this somebody else saying, I look at you and I've identified you as part of this group, and now I'm collecting information about you. So there's very little that's known. Like this is a great start, what we're even seeing today, that we're actually asking the right questions of how do we identify ourselves, and then from that, how do we gather both qualitative and quantitative information of what these differences are. So we know when we feed off of that, there are comorbidities that are greater in our communities, but what are the reasons for them? We hear these terms all the time. We talk about social determinants, we speak about other things that impact it, but I find that it becomes synonymous with finances and things like that when there are other social determinants that impact. Recently, we had a conversation with the Minister of Health, and they've actually acknowledged that racism is a social determinant of health. So it's not only things we have this narrative that when we want to speak about diverse groups, there must be a language barrier, there must be a geography barrier, there must be something that they're lesser in social economics. That's not necessarily true, because we are seeing these disparities across the board. Even when those differences are accounted for, there's still health disparities that are there that we need to speak about. So I know like this last term, it feels very aggressive or it feels scary, but the reality is whether it's perceived or whether it is real, this is how people who are marginalized or are visible minorities experience the healthcare system, and it's something that we here in Canada have to address. We always refer to it as if this is a problem everywhere else, as if this is, we don't see color, we do not have this problem, we are one group of happy Canadians. And to some extent, it's true in terms of what we are striving for, but the reality of how it is perceived and experienced, we haven't attained that yet. And the conversations that are happening, especially within the diverse communities that I speak with, are not aligning with what's happening clinically. It's not aligning with the perception of how we are being received. And I mean, there's examples like even recently, I think Stevie Wonder is getting a kidney transplant this week, and the conversations that were in our community was like, how did that happen? It must be magical. It's not for everybody. We don't think that this is something that's widespread. We don't think that donation and what's happening is for us, and it's something that has to be addressed. It's very hard in our very polite Canadian context to speak about it, but we have to be able to identify what does that look like of why these barriers are happening, other than just the things that we've spoken about earlier today. So back to the modifiable factors, because we don't want to have this as like a doomsday, there's nothing that can be done, there's just this disparity and there's nothing else. How do we address it? So when we speak to community members in whatever field, whether it's in living organ donation or in oncology or anything across healthcare, the thing that is a reoccurrent theme is this idea of trust, and I know a few people have said it today. I think the difference between our community and other communities, there's historic events that have happened that we perceive that the healthcare system is not in our best interest. So, we like to always speak about what would change this would just be further education. But I think that it's not necessary that in other ethnic groups they have greater education. We're not expecting everyone to do, a round in nephrology in order to be able to, ascertain and know more about their health or be able to advocate for themselves. I think what the education is needed is on both sides of how do we support each other and understand the way that we present might be different, the way that questions are asked might be perceived differently, and how do we rebuild that trust between clinicians, front care health workers, between communities, so that they see themselves as actually this is part of this system. There's great, historic injustices have been done, not necessarily in Canada, just on a whole, and it's become a cultural narrative that this system is not for us. And unfortunately, sometimes that narrative speaks louder than the actual clinical information that's being given, and it leads to widening this gap of mistrust. And I think it's one of the first things that, at least in our community, we have to acknowledge in order to, decrease some of these disparities that we're seeing. So the other thing that a lot of people are asking about is this data information, which again, we're seeing a lot of that's here, but how do we collect this data? Who is collecting it? How is it analyzed? We talk about this race-based information, but we can't even agree on how we collect and describe one another. When I was even doing my graduate work, it was funny because I did it in America, and so they think Canada's just one big place, right? Everyone's in Toronto or one place only. And so when I was actually doing my cohort, I had 400 families, and one of my advisors thought he was so progressive. He was like, well, we want to make sure we're inclusive and representative of Canada, so we want to make sure you have the Eskimo population. And I was like, there are so many things wrong with what you just said. But that same type of, preconceived notions happens even within us, within our own internal, the way we see communities, right? Like that, it's easy for us to say, oh, they think we all take sleds to school. But we have those own things between our own communities. So we need to be able to have a better systemic way to identify, how do we define this? And then how do we study it? How do we disaggregate data so that we know who and what we're talking about so that we can help in specific areas. And in order to do that, we also have to have representation, as Dr. Musi was saying, from those communities. This can't be an outside in. If you want all of these things together, if you want to collect information, you want to analyze it, you want there to be trust, it has to be in collaboration with those you are studying. This is not a zoo. You are not coming into communities and just observing. It has to be a collaboration on every level. We can't be expecting to come to speak to people and you never see anybody that looks like you. We've had patients say, in very basic things, very well-meaning information that's sent out, they're like, well, I didn't see anyone that looked like myself or my children, so I just assumed it wasn't about me. And it's something that's very basic, but when you are going through the system and you are scared or you have mistrust or you have all of these other narratives in your head, it's very important to feel like you've been considered, even in something as little as these images reflect who you are. And that's kind of what cultural awareness means. So just to end it is kind of like we speak about how do we increase cultural awareness? How do we increase cohesion? How do we make ourselves feel trusting on both sides and educate one another? There's real tangible ways to do it, and there's surface levels. So I always like to talk about, we think sometimes we'll have a potluck and everyone brought some food and now we've done our ethnic part, everyone's kumbaya, right? That is not cultural awareness. It's nice, I like to eat, I love it, but it's not actual, significant, impactful ways to ensure inclusion. We don't do that by, what we have a perceived, how someone would like us to speak to them, or applying because, I spoke with one or two other members of your identified group, that now we have a handle on it. The whole point of this is, as all healthcare is striving towards, is to have personalized care. So it's like, yes, we have the resources available, we have connections to community. We can say, if needed, we can provide culturally specific or racially specific or religious specific information, but we do not walk in with the assumption that you adhere to that specific stereotype or whatever it belongs to. So the real change that has to happen is systemic. It's all of us as healthcare providers, all of us as part of the community, teaching one another to say, you know, how do we evaluate what we're walking in with? Am I, as a community member, walking in saying, these people are not trying to treat me, and bringing those biases and judgments in? And likewise, the other way around, in our short period of resources and time, are we walking in and making assumptions and inadvertently applying it to our patients? So the first change to decreasing some of these disparities that we're seeing is asking ourselves the questions of, where have these breakdowns happened? How can we consult and work in partnership? And once when we have developed all of that, that is what real education would be on both sides, that we believe will start to decrease some of these numbers that we're seeing, that the outcomes in our communities can be improved with this type of joint understanding. So that's a perspective from my Black community, however we would like to define it.